NICE guidance for the management of self-harm, and leads the programme at the National Confidential Inquiry. So does lots of work with NCISH for suicide and safety and mental health. He chaired the group that informed the NICE guidance and is also their top advisor in terms of the guidelines. That's about as funny as I'm going to get. He left the introductions to me. So I'm going to hand over straight to Nav, because I know you're all extraordinarily keen to hear from him, but put your questions in the chat and I'll come to them at the end. So over to you now.
Lovely, thank you, and thank you so much. I really, really love being described as a top expert. I'm liking that. But I should just correct one thing. So I've chaired many NICE guidelines in my time, including ancient kind of NICE self-harm guidelines. This time I didn't chair it. This time I didn't chair the guideline. Oh, could you mute yourself? I'm getting snippets of other people's conversations, which, while interesting, are a little bit distracting. So if you could just mute yourselves, that's great. So yeah, so I didn't actually chair the latest guideline. Jeremy Isaacs, who's a neurologist from London, would be a bit upset because he chaired it, because NICE have now moved to a system of non-expert chairs. But I was involved as an expert advisor. So I'm really delighted to be here. I spoke for Anne on the self-harm guidelines at the Welsh Suicide Prevention Conference. It was a really good event, and those of you there, I will kind of update that presentation, so you're not going to simply get the same one over. So I'll start by doing what we all love to do, which is share our slides. Let's hope this goes smoothly. Anne, can you see that? Yes, I can see you nodding. Very good.
Yeah.
Wonderful. So the NICE guidelines for self-harm, they are new. They're really, I suppose, newish now, because we published them in September of last year. But I'm going to talk today over the next 40 minutes or so. I'll give you a little bit about the context, which is going to be familiar to basically everyone on the call, but just give you my view on where this new guidance actually sits. I'll then give you an inside peek into the guideline process. I know some of you involved in guideline development, others, you know, it's a kind of mystery, and some of you are a bit kind of mystified about why we come up with the recommendations that we do. So a little bit about the guideline process as well. Then the main thing that you've come to hear about today is the guidelines themselves. So I'll just take out some of the selected highlights and think about the implications for those. And then, as I say, I want to take things a bit further today. So I want to focus on some of the implementation issues and how we can better implement not just the NICE self-harm guidelines, but guidelines in general, because I know not everyone on the call will be, you know, you'll have your own guidelines. It might not be NICE that you look to, but thinking about how we can more effectively implement what we know. So let's start with a bit of context. So I often start my talks on self-harm with this slide, and it's a kind of reminder really. So for years and years and years, people were saying, well, you know, we're really worried now about the incidence of self-harm. It's getting more common. Some people were using unhelpful terms like epidemic. I really hated that terminology. And our response really was, well, we don't think self-harm is going up. We think it's an ascertainment issue. That is, we're becoming more aware, we're recording it more effectively. That's probably what's going on. One of the great things about being a researcher, and Anne will know this as well, is you get to prove yourself wrong. So here's a study in which we proved ourselves wrong. This is a study first authored by Kathy Morgan, looking at self-harm from a primary care perspective. So this is self-harm, if you like, coming to the attention of primary care over time. And what you see in the graphs on your screens there is the incidence in boys over time. So fairly flat there. The bottom graph is the incidence of girls, and for young girls aged 10 to 12, nothing much going on in terms of trends. For older girls aged 17 to 19, again, a flat trend. But there's this, which is self-harm in girls aged 13 to 16, and that's a 70% rise. Now, that can't be an ascertainment issue, can it? That can't be us being more aware, because if we're more aware, it would happen in all age groups and in boys as well. So an increase there. So, we were quite puzzled about this. Lots of speculation. This is all social media. Social media can be both good for mental health as well as detrimental. But obviously that got a bit of attention. But other things, educational pressures, wider media influences on suicidal behaviour, just the mental health of our young people. What is going on here? So I was looking and puzzling over this graph, and over my shoulder, my daughter, one of my daughters, my teenage daughter, looked over my shoulder and said, "You just don't get it, do you, Dad?" And I said, "Actually, I think I probably do get it. I've been, studying self-harm for about 25 years, so no, I do think I get it." And she said, "Well, you just don't get what this is about, do you?" And I said, "Well, look, tell me more." And she said, "You've spent the last, 20 odd years destigmatizing self-harm, haven't you?" And I said, "Yes, that's an excellent thing. We need to destigmatize mental health. We need to destigmatize self-harm." And she said, "Yeah, I agree it's a good thing, but sometimes, maybe things go too far and destigmatization becomes almost normal. So normalization." And she was telling me about her friends and how self-harm was seen as almost a normal coping strategy amongst her peers. I think there's something in that. It's not the whole explanation by any means, but this idea of a kind of cultural shift in our attitudes towards self-harm, I think, is really important. And of course, it's another really important reminder of listening to people who know what they're talking about. So be that young people, be that service users. If we want to understand self-harm, they're the people we need to talk about. The other thing that's really important in this study is the inverse care law. Really important at a time when we're all worried about inequalities. So the inverse care law, basically, young people from the most deprived areas who had the highest rates of self-harm were least likely to access care. So inequalities, socioeconomic inequalities in accessing care, availability of care, that isn't specific to self-harm, but really important in terms of inequalities. That's young people, but of course, self-harm doesn't occur just in young people. Occurs across the age range. This was a study again, Kathy Morgan, again, primary care, looking at the risk in older people. So older people self-harm too. One of the really importance about self-harm in general, but in older people in particular, is the link with suicide. So older people who harm themselves were about 145 times more likely to die by suicide than older people in the general population. A reminder of aftercare, only 1 in 10 referred to mental health services in this study. And the importance of recognising that not all self-harm is the same. So in older adults, the precipitants, the antecedents are different: psychiatric disorder, physical illness, bereavement and social isolation in older people, different things in younger people. So self-harm across the age range and the association with suicide. So since all of that, a few things have been going on, haven't they? And I think that represents quite a big challenge to implementation.
Please could everyone mute?
Yeah, just hearing someone fiddling with papers on their screen. So.
Nav, I can't hear you. You've muted yourself.
I don't think I've muted myself. I think that maybe we've muted the paper ruffling. But anyway, I'm back now. So a few challenges to implementation: the pandemic, the cost of living crisis, and the wider problems in many health systems, particularly pertinent today, junior doctors strike. That's a big challenge if we're thinking about implementation. In terms of the pandemic, a lot of you have seen me put up this graph before. It's data on self-harm, study led by Sarah Steig and Matthew Carr. Big story: early months of the pandemic, a fall off in presentations for self-harm in primary care, as there was a fall off in many other conditions. But look at the green line here. The green line is young people. rates going up for self-harm in primary care. So really important to keep a close eye on it. This graph ends at 2021. People are always asking me, what about more recent data? 2 weeks ago, Alex Trafford and Permock published this paper updating the analysis, looking at self-harm in primary care. And what they found, look at the top graph there, self-harming girls, big increase compared with what might be expected on the basis of previous trends. No increase in boys. Lots of unhelpful headlines about that. Massive increases, striking, very big increases. But really overplaying the increase. I don't think that kind of narrative is particularly helpful. But we do need to understand what this is about. That this increase again was mostly in 13 to 16-year-old girls. So there's something around that. But in order to interpret this, I think we have to kind of take a slightly longer view. So in the supplemental files in that recent paper, there's this graph which takes a long view. And what we've got here is we've got this kind of long-term increase in self-harm. This is primary care, followed by a sharper increase since the pandemic. So, it's about accounting for both of these things, kind of longer term increase. That could be ascertainment, could be mental health pressures, educational stuff. And then, a sharper increase that might be related to the pandemic, could be kind of cost of living type stuff, could reflect services, particularly child and adolescent mental health services, people well documented kind of pressures in those services. So we have to understand the context here. And we have to continue to monitor it. Okay, so that's a little bit about the context. Let's give you some of the secrets now to the guideline process. Why do we need guidelines? Well, here are some reasons we need guidelines. So this is the latest data. It's over 10 years old, this study here, where we looked at variations in care. And care is really variable for self-harm. So this is the proportion of people getting assessed after self-harm. Everyone should be assessed after self-harm. There's this portion getting assessed. Some places it was about a fifth. In other places it was over 90%. So one of the reasons we need guidelines is the variability in care. Another reason we need guidelines is the fragmentation of care. The Samaritan's report, and the title tells you everything you need to know. Pushed from pillar to post. So it's this idea that self-harm services are fragmented. People get referred into community mental health teams, referred back to GPs, referred into particular services not meeting the criteria, get bounced around the system. So fragmented care is another reason for guidelines. And then there are examples of excellent care, absolutely there are. But there are still examples like this that I'll leave you to read. This is from an older systematic review we did, but still, I'll still hear of service users, patients telling me they didn't get the care that all of us would have wanted them to have got. So still stigma around self-harm. I'm a big fan of guidelines. Someone once unkindly described me as a guideline junkie. I'm not that, but I do think guidelines are good. Why do I think they're good? They can reduce that variability. I think they can drive up quality of care. And they also act as a kind of vanguard, kind of galvanizing kind of phenomenon where, service users and policymakers can kind of say, look, here's a self-harm guideline. This is the care we need. Policymakers can often use it as a additional lever to secure more funding. So big fan of guidelines. Guideline development process though can be quite kind of long. So for the self-harm guidelines around 2.5 years. For the depression guideline, that's a whole other story. That was 7 years. And the guideline process is being revamped. But this is how NICE used to do things, and it's one of the great strengths of the NICE guideline process because it's so kind of robust and meticulous. So a topic gets referred. There's initially scoping to decide what's in the guideline and what's out. Lots of kind of a big long period of development where there's lots of guideline meetings, consultation goes out for consultation to all stakeholders at least once, and it's kind of validated. All responses are answered, on the.
Who's Nava's muted again?
Nav, you're muted again. I don't know what's
How long have I been muted?
For like 10 words.
10 words. Okay. I don't know how that's happening. Actually, apologies. I'm not pressing any buttons, I promise. So this is basically the guideline development process. It's robust and meticulous. And how do we actually do that? Well, it tends to be guideline meetings. Of course, in the past, it used to be physical meetings. This is one of the rooms we used to meet in, where you have experts around the table. That's service users, experts by experience, clinicians, academics, service providers, people from social care, members of the technical team, a big team of people. Primarily considering the evidence. So that's one of the things you need to bear in mind when we're talking about NICE guidelines, is that they're based on the evidence. So we do things like we'll consider randomized trials and forest plots, but we'll also consider cost effectiveness. And that's a really important part of guideline. That's a really important part of guideline development because, healthcare resources are limited, as we all know, and people want to spend the money. Quite rightly, we should all spend the money on things that are going to give us the biggest effect for a fixed amount of money. So cost effectiveness, really important. So lots of hard science as part of the guidelines. But in an area particularly like self-harm, there isn't a study for everything. So there's gaps in the evidence base. What do we do then? Well, that's the dark art part of the guideline, where actually it's these people around the table reaching an expert consensus. Okay, so some of it's evidence-based, some of it's consensus-based. And that's why some of the, sometimes people say, oh, it's a bit vaguely worded, some of the guidelines now. Could you not have done better? Believe me, every word, every sentence was pored over carefully by the NICE team. And it's about getting a consensus. And sometimes some of the recommendations are a bit almost intentionally vague, because these are guidelines. Remember, it's the the clues in the title. They're guidelines. They're not kind of mandatory. They're not written in stone, but that gives you an insight into the guideline process. Just seeing how I'm doing for time. We're doing very reasonably for time. So let's go to the new NICE self-harm guidelines. Then let's talk about some selected highlights. There's the link published in September last year. One of the things I'm often asked about is, well, what's different about these guidelines compared with the old ones? The first thing that's different is it actually combines the new guideline in one place, the old short-term and long-term guideline. In the past, we had this rather artificial distinction, and this now puts all the NICE guideline for self-harm in one place. So that's one thing. The other thing we tried to do here in this guideline is to recognise that self-harm can present anywhere. So this idea that self-harm can be, everyone's business, it present to education, present to criminal justice systems, present in workplaces. And that's not to say everyone needs to be an expert. Actually, when you look in the front about who it's for, quite a lot of it is still focused on health and social care professionals. But for these other groups, we're not wanting everyone to become an expert in self-harm assessment and management. Of course we're not. But because self-harm can present in any of these settings, people need to know kind of what to do. They most importantly need to know who to refer on to. So this idea that self-harm can present anywhere and anyone might end up dealing with it. Let's go and say about first contact. I think that's really important. So this is the MRI, Manchester Royal Infirmary, just down the road from where I'm speaking to you now. When someone presents, what should the priorities be? I mean, the first thing should be, really pertinent, given what we've already said about stigma, is treating the person with respect, dignity, and compassion. That's a top line, if you like. But also, when they present to healthcare, one of our responsibilities as health and social care professionals is to keep people safe. So safety and compassion, I think, are some of the key principles there. But also referring people on, so getting people in to professionals who can do a full assessment in many places, in many hospital settings. That's liaison psychiatry, general hospital-based mental health services. Assessments, a proper assessment is key. We've been going on about this since the 1980s, a full kind of psychosocial assessment. There's lots of detail in the guideline about, what you might include in an assessment, but the content is important, but just as important as the content, perhaps even more important, is the how. Is the how we carry out an assessment. So it should be collaborative, therapeutic, kind of compassionate, and understand the reasons for why we're doing the assessment. We're developing a kind of shared understanding, and then hopefully providing the care people need. And we know in the bottom corner of the slide there, just providing an assessment can reduce the risk of repeat self-harm. So just the assessment on its own can be therapeutic. And there's other important things about the assessments, not delaying the assessment until medical treatment, for the self-harm actually occurs. Medical, physical treatment and psychological treatment can occur concurrently, taking into account, of course, the service users' needs and preferences. And even now, in many emergency departments, assessments are being carried out in poorly designed areas, with a curtain across where people can hear conversations. We still need private designated areas for professionals to carry out the assessments. And we need to involve others in the assessments. So involving family members and carers, obviously with the service users' consent, but in general, when we involve family members and carers, that leads to better outcomes. And one of the things I know, speaking as a mental health professional, one of the things we have done, I think, in the past is slightly hidden behind this notion of confidentiality. So we've almost not shared information as a default because of confidentiality, whereas the default should be, obviously with the service users' consent, say, well, in general, things work better. We're able to provide more effective treatment for involved families. Is that okay? So that should be the default. Obviously, in individuals, in some people, that isn't a great idea. It can actually make things worse. But asking the question, involving the service user, and there are some great resources out there that talk about some of the practical aspects of involving families, how we do it better, and we've also done some recent research around that. Involving family members and carers is really important principle. But there are things that we should do. How about some things that maybe are less helpful? So risk assessment, so holistic assessment, that psychosocial assessment, I think is really important. What perhaps is less important is reducing that to a kind of risk assessment. So many of you will know the kind of thing I'm talking about. So people being labelled as high, medium or low risk. In other areas, it's simply a kind of traffic light system. So those broad categories of risk. In other places, just risk assessment tools. This is a study we did a while ago where we asked every mental health service in the UK for copies of the risk assessments, about 60 odd services. The tools varied from 1 to 20 pages in length, and from 60 mental health services, we got 156 different risk tools. So why aren't they a very good idea? There's some real world data where people who self-harmed were categorised as low, moderate or high risk. And you can see maybe there's some validity to this. Of people in the high risk category, about 26% of people repeated. In the low risk category, about 10%. People repeat. So I might be saying, well, actually, there's some validity to that risk assessment. The problem, I think, comes if you just focus on the high risk group. So Found and colleagues develop a new digital intervention that's really effective following self-harm and maybe even prevents anyone from repeating self-harm. You'll probably focus that on your high risk people. If you focus it on your high risk people, that's great. A new intervention focused on high risk people, you'll prevent 95 repeat episodes based on this real world data. The problem, of course, is that low risk paradox, because although you prevent the 95 cases, because you're only providing treatment to high risk, that's the whole point of the high risk paradigm, you'll miss all the people in the low and moderate risk group. So although in percentage terms they're at low risk, because these are big groups, they account for more of the repeat episodes. So at best, you're only going to prevent about 1/6 of repeat episodes. What about risk tools? Surely they're a bit better than these broad categorizations. No, they're not. So we were constantly asked what's the best scale. So we did this study. Leah Quinlivan, my colleague, led it. Again, real world data in NHS settings, where we looked at the best scales and we compared them with the clinician or the service user just putting a cross on this 10-point scale. And then we followed people up and to see who repeated self-harm and who didn't, to see how good the predictions were. This is a ROC curve. What does it tell you? Basically, the best scales around here, and the best scales were included the clinician just putting a cross on the 10-point scale, the patient putting a cross on the 10-point scale, and actually this very brief item that we developed. But none of these were good enough to be used. They still had the problem of excluding that low risk sample, and some of them were no better than chance. So when people ask you what's the best risk assessment tool, the answer is none of them. What do we say about risk tools and scales? Don't use them to predict future suicide or self-harm. Don't use them to determine treatment. And we actually went further in that we shouldn't use those broad risk categorizations. Still lots of scales out there, some really elegant epidemiological work out from Oxford thinking about kind of risk. But in terms of real world use of scales, we shouldn't be using them in this way. I was thinking about risk assessment on the way in this morning, and how actually it's probably the wrong focus. It means we're neglecting other things. So if staff are telling us they need risk assessments or need checklists in order to assess patients, then that says something about training, I think, and how we need to kind of improve training, and maybe training should be the focus rather than risk assessment. And the other thing I think it detracts focus from is interventions, and I'll go on to talk about that, because actually there's no point in stratifying by risk if you've not got the interventions, and we haven't really got the interventions widely available. What should we do instead of risk assessment? We talk about risk formulation, where you're drawing together the risks in order to inform a management plan, and then really a focus on a person's needs rather than risk. So when tragedies do occur, the thing that comes up again and again in serious incident reports is a risk assessment wasn't done. I don't think that's right. Actually, it should be about, well, was the relevant information collected? And sometimes, the information won't have been collected, and we will need to address why and how we remedy that. And sometimes the information is collected, and then the question should be, why was that information not acted upon? This idea that, oh, no risk assessment in place, that really isn't, that really shouldn't be the focus. It should be a wider process focus. Okay, I'm going to skip through some of this now quite quickly, because a lot of it will be familiar to you. Safety plans. I know many people on the call will be familiar with safety plans. This idea that, after a self-harm episode, professionals will sit down with the service user to think about warning signs and then contingencies if things don't go well again. Who you're going to contact, who you're going to ask for support. Again, the exact content of the safety plan is probably less important than the how. So using it collaboratively and compassionately, sharing it and making sure it's accessible. So I know of safety plans where neither the service user or the professional can access it. It's a consider recommendation in the NICE guidelines. People say, well, why haven't you mandated it? Why don't you say must? And that's because the RCT evidence, the randomized control evidence, isn't as strong as you might think. So the consider is, if you like, a lower level of evidence. But do I think safety plans are a good idea? I absolutely do. Aftercare. What are the key principles of good aftercare? The first is communication. So communicating with the service user and their families of purpose, format, frequency. And the other principle of aftercare is getting in there quickly within 48 hours. Why is that? Why do we want to get in there within 48 hours? Because if people are going to repeat self-harm, they do so quickly. So here's some epidemiological data. And basically, it's showing you that 30% of people repeat within a month, who are going to repeat within a year. And 1 in 10 people repeat within 5 days of those who are going to repeat within a year. So 1 in 10, 5 days. Long follow-up, outpatient appointment in 2 weeks. You're wasting your time. We need to get in there quickly. Interventions for self-harm. So the NICE guidelines says quite a lot about interventions. Remember, self-harm, we're talking about self-harm today. We're talking about, poisoning, self-injury. We're talking about regardless of intent. So we're not just talking about non-suicidal self-injury. We take into account the spectrum. But it is a behaviour, not a diagnosis. It's a behaviour diagnosis. And lots of complexity, lots of underlying conditions might be accounting for the self-harm. And in general, NICE have got a guideline for that. So the underlying conditions, the underlying kind of contributing factors, there NICE encourage you to follow the guideline most relevant, but also the role of talking treatment. So in the guideline, we talk about cognitive behavioural therapy informed treatments. In fact, it's a forest plot, 50% reduction in the risk of repetition after a psychological intervention following self-harm, wide variety of different things. It's not just pure CBT, problem solving, interpersonal type therapy. Between 4 and 10 sessions, something focused on self-harm, taking into account needs and preferences, and making sure staff are appropriately trained and supervised. That's interventions. Of course, no discussion of interventions would be complete if we don't include also the prefix digital. The actual evidence base is a bit mixed, and what's also entertaining is different colleagues and different people interpret that evidence in different ways. Colleagues in Australia, friends and colleagues in Australia, want to go for it right away. Other colleagues, thinking about maybe further research. I think, digital interventions are here to stay. It is an area, one of these areas which we do need a bit more research. And NICE have actually, since the publication of the self-harm guideline, recommended digital interventions for things like anxiety disorder, depression, and I imagine in the fullness of time, some of the evidence on digital interventions for self-harm and suicide will be developed to such a degree that NICE will be recommending digital versions of some of those effective interventions. So this is an intervention. In some ways it's an intervention, but it's a really thorny issue, harm minimisation. This perhaps speaks to living with self-harm. So lots of service users say, well, actually, now if I use my self-harm as a coping strategy, it would be detrimental for me to kind of stop. I think for me as a kind of clinician, the aim is always to try and reduce self-harm, even if it's a coping strategy, perhaps thinking about other coping strategies. But harm minimisation speaks to that kind of living with self-harm, and covers a lot of different things. Some people talk about distraction techniques under harm minimisation. Other people talk about alternatives to self-harm. Other people talk about safer self-harm. Covers a lot of different things. There's some papers on it, not a huge amount of evidence, and really in the guideline we didn't make any recommendations about the use of safer self-harm. There's not sufficient evidence, but there are some, I think, principles that services need to follow if they're considering harm minimisation strategies, and it's about doing it in the right kind of spirit. It's about it being kind of collaborative, and it's about not seeing it as a standalone intervention. But again, something pretty controversial. I'm sure it'll come up in the chat. It always does. But harm minimisations, we didn't say a huge amount about it because there isn't a lot of evidence. We said a bit about training and supervision. It's really important to have a workforce who are trained and supervised. But then I get asked the awkward question about what training should we give people, and the answer to that is I don't know. There isn't the evidence on the exact type of training, and is one training package better than the other. But we do have this competence framework that we developed a few years ago based on the old NICE guidelines. We're hoping to redo it at some stage. What's a competence framework? It describes the key skills, knowledge and attitudes that we would expect staff to have when they're dealing with someone who self-harms. And what we encourage people to do is audit their own training if they work for a health or social care organisation against the framework, or for people developing their new training, make sure it's kind of consistent with the framework, because it is kind of evidence and consensus based, this framework, and we think is a useful starting point in any case. Just some quick general principles now. This is flitting different bits of the guideline. One really important principle is self-harm, characterised by the management of self-harm, characterised in many services by this principle of exclusion, people being excluded, and this idea that we can't use diagnosis, age, underlying conditions, substance misuse as a reason for withholding treatment. That's bad, we shouldn't do it. Equally, there's no role for aversive or punitive approaches. A lot of you will know about the Stop Sim coalition. There's no role for that in self-harm care. Let's be absolutely clear. Not offering drug treatment as a specific intervention to reduce self-harm, of course, to treat underlying conditions such as depression. Pharmacological treatments have an evidence base and can be effective, need to be tailored to the individual, but as a specific interventions, we wouldn't offer them. Thinking about this balance, certainly in acute settings, safety versus kind of autonomy, using the least restrictive measures. I think that's a really important message. And one thing I think I've neglected, and we've neglected the role of, you know, we've neglected the importance of it is continuity of care. You know, a lot of people tell me, look, it's just not practical to have the same person doing the assessment and the same person doing the follow-up. And I kind of get that in you know, complex health systems, but then at least having maybe continuity of care team or informational continuity. So, you know, the fact that, you know, different sets of records talk to each other, the idea that when a professional comes to a care record for service user they haven't seen before, they can access all the relevant information, so the service user doesn't have to repeat the story. So you've had a bit of context, you've had some secrets of the guideline process, and you've had a real whistle-stop tour of the guidelines. I encourage you to look at them in more detail because I've by no means covered them all. Just in the last 5 minutes then, thinking about how we implement not just these nice self-harm guidelines, but guidelines in general, and what strategies we might use. One strategy I think it's a bit controversial, but I think probably kind of works, is the use of incentives in healthcare. So in England, we have something called the Sequin, and these are really kind of targets, I suppose, for health services, not just mental health services. And for ages, we've been trying to get one around self-harm, and we've got one finally around self-harm. It kind of expired in April of this year after running for a year, but that was focused around improving the quality of psychosocial assessment. So this crucial aspect of self-harm care, improving the quality, encouraging services to self-audit and identify gaps in care. And for those of you interested, on Monday, we're having the wrap-up meeting for the Sequin for self-harm. But these incentives where services get a bit of extra money for, you know, improving quality, I think can be really helpful, can help guideline implementation. The other thing I think that's been really effective in terms of implementation of self-harm service developments is local innovation. So this is a part of a programme we're involved in throughout England, community mental health transformation projects, where basically individual areas develop little quality improvement projects focused on an area of self-harm. So this is Frimley, where they're focused on psychological intervention. This is Somerset, where they thought about digital resources and using a QI approach. What's a quality improvement approach? Well, it's about rapid little, we call them PDSA cycles. Basically, you make rapid little changes in services, in care pathways, you monitor the effect, you make more changes, and you kind of hone your service so it's having the most effect. So rather than waiting for that cycle of, you know, me doing research, colleagues kind of writing the research, you know, publishing the research, waiting for that, which takes about 20 years, we're looking at a rapid QI type process. And there is evidence that works. This is a really interesting trial came out recently, I thought I'd tell you about, where this was a QI approach. This was in the States, in 8 emergency departments in the States. Did some things we wouldn't do, so suicide risk screening. Did some things we, you know, probably would do, so safety planning. But the key element of this was in each of these emergency departments had a QI lead, quality improvement lead. They convened a multidisciplinary team with clinicians, information people, quality people, and a one-day kind of quality improvement kind of coach came over and did some on-site training. And then this idea that, you know, you continuously evaluate your care pathways, identify gaps between current and optimal care, and then develop local solutions to try and do that. And it's an iterative approach where you're constantly collecting data, constantly making improvements. And what these authors were able to show, really interestingly, that's a baseline phase, but in the implementation and maintenance phase, looks like it resulted in reduced repeat attendances, for suicidal behaviour, suicidal ideation too. That was one of the outcomes in this study. Interestingly, things may have got kind of not worse, I suppose, but there was this jump at the beginning of the implementation phase, and that's a really important message, that if you're going to do effective implementation, you've got to kind of keep at it. So it's not about what happens at the beginning of the implementation phase, it's what happens once you've kept at it. The other thing I think that's crucial for effective implementation is being quite imaginative about, the settings where we're doing the implementation. So most of my career has been focused in mental health services or liaison psychiatry or self-harm services. Primary care, I think, is a really neglected area, and I know one that's of interest to Anne and colleagues as well. 80% of people in contact with primary care before a self-harm episode, similar proportion before suicide. So real opportunity to intervene. This is my colleague and friend Faraz Mughal, who published this, thinking about what the role of primary care might be. There's obviously this idea about when and who to refer to. Something about continuity, primary care continuity, I think suffered. Is there a way we can bring that back? The role of safer prescribing, the role of kind of accessible aftercare. So if we want to get more effective implementation, means implementation across a wide varieties of settings, and also seizing new opportunities. So in England, we've got a new suicide prevention strategy coming out this year. Probably later in the year. Now, we had thought it was going to come out over the summer, but probably later in the year. We have the self-harm guidelines. In Scotland, they released their suicide prevention strategy last year. They've got a self-harm strategy coming out this year. And I know Anne and colleagues are working on suicide prevention and self-harm prevention strategies in Wales. So every time one of these new strategies come along, it's a new opportunity to kind of galvanise effort to really push implementation. And in our English strategy, it's going to be things that haven't been in the strategy before, but also self-harm, the central role of self-harm. That's always going to be in suicide prevention strategies, and our new one will be no exception, and that's an opportunity. So I've told you a little bit about the context. I've given you some secrets of the guideline process, a very whistle-stop tour of some of the content, and then thinking about how we make sure those guidelines aren't just left on the shelf, but they're implemented. And then just to summarise, just to remind you, we need better care for self-harm. I think clinical guidelines do improve quality, reduce that variability. There's things in the guidelines I think are kind of key elements. That's the assessment, which needs to be the how. Remember, the assessment's important. Don't just focus it on risk. Aftercare, it's about well communicated, but most importantly, perhaps timely, getting in there quickly. Treatment, the role of psychological interventions, which I think still aren't widely available after self-harm. Haven't really mentioned safer prescribing today, but we can pick that up in the chat. Care can't exclude people, mustn't be punitive. Continuity, I think, is important and something that's been neglected today. And I think we really need to think hard for any strategy, for your local strategy, for any strategy. It isn't just about the strategy, it's about making it work and implementing it. And the last thing I'd like to do is just thank all the people back here in Manchester who do all the hard work. Apologies for the minor technical issues, but I shall now stop sharing my screen.
I'm just unmuting myself. Thanks so much, Nav. There's been lots of comments in the chat. And all the thank yous are coming through. I guess one of the questions that was asked was, have you got any thoughts on how to manage self-harm and substance use together? You talked specifically about excluding people from services, and this is often the touch point where it happens.
Yeah, I think that's a really live issue, and I think this comes up for a few things. It's not just kind of drug and alcohol disorders. I've been asked similar questions about eating disorders and other conditions, and it's about concurrent treatment. So there are effective interventions out there for alcohol misuse, clinical interventions. We need to make sure they're kind of applied concurrently with self-harm interventions. And if you thought self-harm interventions were difficult to get, many colleagues in the alcohol and drug space will say, look, you know, it's even harder with alcohol and drug services, especially given the fragmentation of service provision. So many of you will know what's happened is for drug and alcohol services, they've basically been farmed out to lots of different providers, and some are excellent. Colleagues in the voluntary sector doing brilliant work, but it is this fragmented picture. The other bit of the drug and alcohol story, though, and you know, Anne, you'll totally kind of appreciate this, is, you know, sometimes people like me are talking about clinical interventions. Of course, they're important, but the other bit of this is the public health and policy response. You know, and one of these days, I'm hoping one of these days, no one will challenge me to a debate on clinical interventions focused on self-harm and suicide preventions versus incidental public health interventions, because I suspect some of those incidental public health interventions, so minimum alcohol unit pricing, things like in the suicide prevention space, you know, things like you know, car exhaust fumes, which is a kind of method of suicide. Sorry to talk about methods, but we're in a webinar on self-harm. You know, that was an ecological measure where car exhausts were made safer, and it resulted in suicide prevention. So there's a public health role here, but then there's also for the clinical interventions and availability and seeing things as concurrent. And you know, staff are busy, not using it as an excuse for exclusion. So sorry, slightly long-winded answer on alcohol and drug services.
I mean, I think it's an excellent answer. As you know, as you highlighted, I think we need to tackle all these issues from both ends, isn't it? The people in contact with services, and then the population level interventions that can shift where we're at. There's another question. Do you think there are priority areas within healthcare where training around self-harm needs to be focused across certain specialty areas, clinically, but also non-clinical providers?
I think, you know, that this speaks to part of the new NICE guideline, which is self-harm is everyone's business. So it's not going to be the same training for everyone. It's going to be different. For me, you know, obviously we need to make sure that training and supervision is fit for purpose in people dealing with, if you like, the most severe and, you know, dare I say, risky end. So it's mental health professionals. But in terms of where you're going to get the biggest bang for your buck, where are the, if you like, where are the biggest training needs? I mean, still, I get questions about, you know, emergency departments. You know, emergency department staff's not understanding self-harm. Perhaps that accounts for some of the treatment that people receive when they turn up to emergency departments. But I'll come back to three areas, I think, where the biggest potential is. First is primary care. So thinking about what we might do in primary care. Again, that has to be something universal for every GP, not, you know, just something people can pick and choose from. It has to be something that fits with GPs' very busy, challenging patterns of working. But there's a big opportunity, I think, in primary care. There's a big opportunity, I think, in the other places where self-harm presents. Schools, what are we doing for self-harm training in schools, and workplaces? What's that? And I've got little enough idea what training should look like. You know, for the first group, we've got, you know, some competencies there to help us. For the other groups, I think there's lots and lots of work to do on that. I've just seen something that's just grabbed my eye. Sorry, Anne, about RCT evidence on safety plan is not good. Please, can you elaborate a little? Shall I take that one?
Take that one. I'm just going to pick you up on. We'll go there next. So as you know, Three Dads Walking have really pushed for self-harm awareness in schools and the teaching of self-harm, whereas lots of the evidence points to social and emotional regulation skills, relationship skills. Have you got any thoughts on both of those?
I think it's really interesting about the whole awareness, and you know, Three Dads Walking have done absolutely. I mean, they presented at our annual conference, magical, great work. There's something, I think, around awareness raising as a standalone intervention, and this isn't our research. It's research, I think, you know, Anne's been involved in similar research, but Jane Purkis led on a systematic review a little while ago, a friend and colleague from Australia. And awareness raising on its own, probably not that effective. But we all think it's a good idea, including me. You know, I've come, oh yeah, okay, it's great to raise awareness. I think there's a couple of caveats around that. I think it shouldn't be standalone. So as a package of other things, I think there's some evidence from the depression literature that it can help. And it's, you know, what my daughter talks about as well. It's not talking about self-harm and suicide is a good idea. That's great, but it's where the awareness raising perhaps strays into cognitive availability. It's kind of term we sometimes use. It makes it more of an option for people. We have to be a bit careful about that, I think. So awareness raising, destigmatization, fantastic. As a standalone intervention, probably not. Needs to be part of a wider package.
It's a very tricky, complex area. I think someone caught it really well in the chat. How do we destigmatize without normalizing?
And I think it's about, you know, this is not a normal, if you like, coping strategy. Some people use it as a coping strategy. It's about thinking about, you know, how if people are using it as a coping strategy, we use it better. But it isn't, you know, a normal way of dealing with distress. And I think we need to, you know, certainly as a clinician, maybe that's easier for me to say, but you know, it isn't an adaptive or good way of dealing with stress. Should I pick up the RCT one? I'm dying to.
Yeah.
So yeah, I mean, you know, some people criticise this at NICE, and I can see it. You know, they say, "Oh, you just focused on RCTs." You know, randomised trials where basically a whole bunch of people, half of people get one treatment, half of people get treatment as usual, and then you compare outcomes. It's still probably the most powerful trial design. It's not the only research design available, and I think I've only done one RCT in my career, and that was a pilot trial that didn't end happily. You can look it up. Messages from Manchester, it's called. So but I think, you know, randomised control trials still at the top of the hierarchy of evidence. When you look at safety plans, a lot of that isn't traditional randomised control trial evidence. A lot of it isn't, you know, directly transferable to the NHS, but a lot of it is quite good research. So when you look, and you can look at the evidence reviews behind the guidelines, so the data geeks amongst you can look at the guidelines, but then you can look at all the evidence we considered as part of the guidelines. You'll see there's not a whole lot of research evidence. So that's why, you know, it's not quite strong. But I know Rory's, I think, done a pilot RCT of safety planning. Rory, a kind of friend and colleague in Glasgow, many of you know. I think they're planning a full trial, and colleagues in the States are doing RCTs of safety plans. So my hunch is by the time the next guideline comes along, which will probably be too late for me to be involved in, but when it does come along, we'll have safety plans in there.
Great. One of the things that you know, it's really amazing that the NICE guidelines highlighted compassionate care. I'm not sure that there are other guidelines that have to state that quite so explicitly. But when you're talking about that, when you're talking about evidence-based psychological therapies, when you're talking about continuity of care, how realistic do you think that is in a health service that is very stretched?
I think this is something that you know, even pre-pandemic I was thinking about, and I'm thinking about, oh, that's interesting. Something very that's a different view where everyone's. I'm now sitting in an auditorium, which is quite entertaining, but also quite
I feel
distracting.
like we're playing that game where we all get knocked over and you've got to guess the double.
But this idea of how we implement in pressured health systems, I think is one of the big questions for our age. And I'm just wondering if someone could change the view. But anyway, anyway, I think it's one of the biggest questions of our age. I mean, a lot of people have a simple answer. They go, "Oh, what we need to do now is we need to go digital." All right, maybe that might be part of the answer. It may be that we can streamline things, but I'm not sure that's the answer. What a lot of this is going to require, I think, is wholesale system and process change, I'm afraid. So thinking about how we revamp whole systems. We've started doing that in England. There's a community mental health transformation programme that you know, we're integrating primary and secondary care, making it more seamless. You know, that's probably some of the way to go, but we're early on in some of that process. But I think just because it's a bit of a challenge at the moment, and it certainly is, I don't think we should give up. You know, there are simple things we can do. You know, the assessment is the thing we pushed with the last guideline. I think, you know, it's interventions and primary care this time round that if we get right, I think we could have a transformative difference.
Any final questions from those on the webinar? I'm not seeing any come up. Earlier, someone asked if you could give your views on what you think the balance is between face-to-face therapies and interventions and digital ones. Yeah,
I think that's a really tricky one, and it kind of speaks to my own biases that I kind of prefer face-to-face. Obviously this meeting accepted, this is the perfect digital meeting, but in general I prefer face-to-face interactions, and therapeutically I do. But there is this big point about access. So I think there is no exact balance, but I think we have to provide a choice of both, because, you know, some young people will tell me that digital stuff is absolutely fantastic. I don't have to, you know, I don't have to traipse over. I don't have to bother my mum and dad. I don't have to traipse over to the clinic. I can, you know, I know I'm going to be on time. You know, I struggle with my timekeeping. Offering a choice going forward is a must. I think that's mandatory going forward. We need to have both. I really agree with that. So I often say it's a toolbox, isn't it? And people can choose what they want. And I think the access issue is really important. We did some work with COOF that some of you may be aware of, provides online support to young people. And, you know, the differences in the number of young people from ethnic minorities accessing that service was amazing. And, you know, I don't see that sort of representation in any other of the work I do. So I think we really need to have that, as you say now, that toolbox really, that people can pick and choose. And it'll be quite age dependent. I think that's right. I mean, people talk about digital exclusion, but, you know, Roger Webb and colleagues have done some work here in Manchester where, you know, it's probably not as big a problem as some people. For some people, it absolutely is. And there you have the you know, the choice of kind of face-to-face and other services. But for many people, it actually improves access, as Anne's saying. So fantastic. Right. So we've come to the end. It was absolutely brilliant, Nav, and I think you're seeing that in all the chat as ever. I learn something new every time, so I always enjoy doing a webinar with you. That's great. Thanks everyone, and I know many of you on the call, and see you next time. It's great. Thanks, Sam. It's really good.
Thank you.
Bye everyone.
Bye.